to our third. Thank you. So thanks everyone for coming to our third mini med school talk of the season. Today's talk is going to be on diabetes. So we're going to go through a little bit about how it develops, the different types, how it's treated and prevented. And we'll have, I think, 6 more talks in the new year as well. The schedule I'll post at the end of this talk if you're interested. And so, as always, I'd just like to start our talk with territorial acknowledgement. So I'm calling in today from Victoria. So I'd just like to acknowledge with respect the Lekwungen speaking peoples on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships continue with the land today. So our optional survey, I think Julia just posted about it in the chat. But again, if you haven't completed it yet, it is different than our one we did in the summer. So please complete it if you think you might attend 6 or more talks over this season, as well as the January, February talks. We're looking to see the impact of mini med school on the community of those who attend our talks, specifically about the impact on people's perception of medical doctors, as well as the impact on the community connectedness that people feel. And as always, this talk is going to be recorded and it will be posted in Dr. Gare's website, the link to which is in an email you just got that had the link for this talk today. And the survey link as well is in that email too. And a couple disclosures here. So I'm a second-year medical student, and as such, this talk is simply intended for your entertainment and education. It's not meant in any way to replace medical advice from your physician or any other healthcare professional. And just to note, all the photos that I've used here are available under a Creative Commons license unless otherwise noted. So thank you for joining us, and we'll get started here. On the agenda today, for the first half of the talk, we'll go through what diabetes is and the different types. We'll then have about a 10-minute intermission and some time for questions. As well, afterwards, we'll come back over the complications, diagnosis, treatment, and prevention of diabetes. And I have a few suggested resources if you're interested in doing some more research on your own time. And then we'll have a little Q&A to end off the session. And just to note, please keep your mics muted throughout. If you have questions, you can post them in the chat while I'm talking. But then if you'd like to turn it on during any of our Q&A periods, feel free to do so to ask questions. So to start off, what is diabetes? So diabetes mellitus is a condition in which your body either cannot produce insulin or can't use it properly. And this leads to the inability of your body to regulate the amount of glucose or sugar in your blood. So what is insulin and how does it affect the glucose? Insulin is a hormone that's produced in the pancreas, and the pancreas is this little kind of orange organ shown here. It looks kind of fatty and it's structured around the stomach and small intestine. So you can see it here on the right, situated near its other organs. And it has these things called pancreatic islets. And within the islets are a couple different cell types. The one that we're going to talk about today are the beta cells, and they're the tiny little purple circular cells in the center of this islet here. So it's the beta cells that produce the insulin. And insulin acts as the key that opens the door to let glucose into the cell. So don't worry too much about the picture here, I'll walk you through it as we go. So the orange circle here is the cell, and the glucose, these little yellow circles, these are outside the cell in the bloodstream. So when you eat food, you absorb glucose into your blood, which then needs to get into the cell to be used. And insulin is the key that opens the door to let the glucose into the cell. And it's shown here, these little red dots. So it does that by inserting itself into the insulin receptor, which acts as the lock. So when you have glucose in the blood, the pancreas senses that, releases insulin, which then goes to the insulin receptors on the outsides of cells. And this kind of lock and key formation signals the door, or the glucose transporter, this little purple and green thing, to move from inside the cell to the surface of the cell, shown on the right here. And when that happens, the door opens and glucose can enter. So as you can imagine, without insulin, glucose cannot enter into the cell, and instead it builds up in the blood. And it illustrates here the two main types of diabetes. So type 1 diabetes in the middle and type 2 on the bottom. So in type 1, you don't produce insulin, so you cannot unlock the door for glucose to enter. Whereas in type 2, you have insulin, but your body doesn't react to it properly. So insulin going into its receptor, that lock and key formation no longer triggers the glucose transporter or the door to open. And this building up of glucose in the blood is called hyperglycemia or high glucose. So why does hyperglycemia matter? And that there's two main reasons. So one is your cells require glucose for energy. So without glucose coming into the cells themselves, they end up starving for energy. And this means that the body needs to find another way to get energy, and it does so by breaking down its own tissues. Number two is high levels of glucose in the blood over long periods of time, or kind of chronic hyperglycemia, will damage many different tissues throughout the body. So I'm going to open up our first poll here. So what parts of the body do you think can be damaged by hyperglycemia? Let me just launch this here. Okay, so the eyes, feet, kidneys, heart, or all of the above. You can answer which ones you think are affected there. And I'll just give 10 more seconds here to answer if you haven't yet. And if you don't know, you can guess, that's totally fine. All right, so I'll end the poll here. And so it looks like the majority of you got it right. It is all of the above. So kidneys is not incorrect. It just happens to affect all of them. And that's because hyperglycemia can damage the nerves, blood vessels, tissues, and organs in your body. So all of those are correct. And we're going to be talking all about the complications of diabetes in the second half of the talk after the intermission. So stay tuned. I'll stop sharing it there. If any of you still have the poll up on your screen, you can just click the little red X in the top left to get rid of it. All right, so we're going to talk about some signs and symptoms of uncontrolled diabetes. So these are things to look out for in yourself or loved ones if you suspect diabetes, but also it's kind of interesting to know how these happen and how diabetes causes these side effects. So hunger and weight loss. Hunger is also called polyphagia. So I kind of group those together, and that's because, like we talked about, glucose cannot get inside the cells, and that leads to the cells to start starving. So your body then goes into starvation mode and starts to break down other tissues. So it'll break down fat and muscle in order to make its own energy. And this, as you can imagine, can lead to weight loss and hunger as well, because you're technically starving. Next up, glucose in the urine, or glucosuria, and increased urination, or polyuria. I'll group those together, and that's because with high glucose in the blood, when the blood ends up going through the kidneys to get filtered, some of the glucose spills over into the urine, and it normally wouldn't be there. And because glucose is osmotically active, meaning that water likes to follow it, you end up getting increased water in the urine as well, because it's following glucose. And this leads to increased urine volume, as well as increased urination. Following suit, increased thirst, or polydipsia. That happens because, as you can imagine, if you're peeing off increased water and fluid, that can lead to dehydration, and your body will respond by creating thirst signals. So you'll end up being thirsty. And then lastly, blurry vision here. So diabetes can lead to some long-term visual problems that we'll talk about in the second half of the talk. But in this case, I'm talking about short-term blurry vision. And you can get this just with fluctuations in your blood glucose levels. And so as we know, water likes to follow glucose. So as glucose levels change, this can affect the fluid levels in your eyes. And that can lead the lens in your eyes, the part that kind of refracts light, it can actually start to swell with increased blood glucose levels as water moves in and out where it shouldn't really be fluctuating, and that leads to blurry vision. And a couple other things on the slide that I'll talk about later on are wounds that won't heal, numb or tingling hands or feet. I'm going to cover those in more of the long-term complications. And just to note as well, the symptom onset of type 1 diabetes is often quite abrupt. So these symptoms might just come out of nowhere, whereas in type 2 diabetes, they may occur a bit more gradually. Now to start off here, I thought I'd go through some history and statistics of diabetes. So the name diabetes mellitus refers to sweet urine, and we typically refer to the diabetes we're talking about today just as diabetes, but there are a couple other types of diabetes. So diabetes mellitus is the specific term for this inability to use or create insulin. So diabetes is the Greek word for siphon or to pass through, and that kind of represents the urine. And mellitus is the Latin word for sweet. So it really just means sweet urine. So Hindu physicians first noted the sweetness of diabetic urine around 400 to 500 BC. And the diagnosis back then was made by tasting urine or putting out a sample of urine and seeing if ants were attracted to it because of the sweetness. And this practice of tasting urine continued centuries later when people called waste tasters diagnosed diabetes by actually drinking and tasting urine. And then next up here, the very first mention of diabetes symptoms dates all the way back to 1550 BC, when Egyptian physicians noted increased urination, or the polyuria symptom that we just talked about. So this picture in the top right of the screen is of the Ebers Papyrus, and that's the Egyptian script that contained the first known description of diabetes. And some local history here. So jumping forward in time, insulin was isolated in 1921 in Toronto by Frederick Banting and Charles Best, alongside J.J.R. MacLeod and James Collip. So Banting was a medical doctor, and Best was a medical student who worked as an assistant to Banting. And they used MacLeod's lab, and Collip was a biochemist who aided in the refining and extraction process of insulin. The first injection of insulin was given shortly after the isolation in 1922 at Toronto General Hospital. And this is incredibly exciting because before this advancement, type 1 diabetes had a life expectancy of only days to months because it's so severe when it's not controlled with insulin. And just to note here, so there's Charles Best here and Frederick Banting on the right, and this dog in the middle kind of represents that they initially isolated insulin from dogs, later found out that would not be sustainable, and they ended up being able to create a synthetic insulin. And of note, they were awarded the Nobel Prize in Medicine, but it was controversially awarded to Banting and MacLeod in 1923, and it skipped over the contributions of Best and Collip. But Banting and MacLeod were kind, and they split their awards with Best and Collip respectively. So now some statistics. So diabetes is on the rise. It's estimated right now that about 422 million adults have diabetes worldwide, and it leads to 1.5 million deaths worldwide as well every year. So the number of people with diabetes has risen from 108 million in 1980 to the 422 million now. This is, I think, 2014 statistics. And this number relates to about 1 in every 11 people has some form of diabetes worldwide. And this prevalence has been rising more rapidly in low and middle income countries than it has in high income countries. And in 2019, diabetes was the 9th leading cause of death, with the estimated 1.5 million deaths directly caused by diabetes. And some kind of interesting facts here. So between 2000 and 2016, there was a 5% increase in premature mortality rates, so dying before the age of 70 from diabetes. And by contrast, the probability of dying from one of the other 4 main non-communicable diseases, so like heart disease, cancer, respiratory disease, between the ages of 30 and 70 decreased by 18% globally in that same time period. So while everything else is decreasing, diabetes is still rising. And these are some local statistics. This is the Diabetes Canada reference. So 1 in 3 Canadians, or 11 million Canadians, currently have diabetes or pre-diabetes right now. And they kind of estimate that every 3 minutes another Canadian is diagnosed. 1.5 million Canadians have type 2 diabetes and aren't aware of it. And there are 6 million Canadians right now who are living with pre-diabetes, half of which will go on to develop type 2 diabetes. And diabetes complications, shown here on the right of the image, they're associated with premature death because it can reduce the lifespan of an individual by about 5 to 15 years if not controlled well. And people with diabetes are 3 times more likely to be hospitalized with heart disease, 12 times more likely to be hospitalized with end-stage kidney disease, and almost 20 times more likely to be hospitalized for non-traumatic limb amputation compared to the general public. So now that we've covered some background on what diabetes is and how prevalent it is, we can dive into the different types of diabetes. So our second poll here, or actually not quite yet, I'm getting ahead of myself. So the different types of diabetes I'll talk about today are type 1, type 2, pre-diabetes, and gestational diabetes. So now for the poll, which type of diabetes do you think is most common? So let me go to the next one here. Okay, so type 1 diabetes, type 2, or gestational diabetes. Okay, just a couple more seconds here to vote. All right, so I'm going to end the poll here. And most of you guessed correctly. So type 2 diabetes is the most common diabetes, makes up about 90% of diabetes among Canadians, whereas type 1% only makes up about 9% of diabetes among Canadians. And the remaining types, including gestational, make up the remaining 1%. All right, so type 1 diabetes we'll talk about a bit more in detail now. So in contrast to type 2, where people have insulin but can't use it, in type 1, you end up having decreased production and eventually complete loss of insulin. And this is because type 1 diabetes is an autoimmune condition in which your body starts attacking the insulin secreting beta cells of your pancreas. So shown here, you have the healthy pancreas, which will secrete insulin, help glucose go into the cell. In type 1 diabetes, your immune system starts eating away and destroying the beta cells of the pancreas, which decrease your ability to produce insulin. And over time, you'll have enough of your beta cells destroyed that you depend on exogenous or outside sources of insulin. So type 1 diabetes is caused by a combination of genetic and environmental factors. It's not fully understood, but there is still a genetic component because having a family member with type 1 diabetes increases your chance of developing it. So for example, here, if both of your parents have type 1 diabetes, your or the child's risk is about 1/4 to 1/10 that you'll get type 1 diabetes. And for the environmental factors, there's some theories that genetically susceptible individuals, some infections could trigger an autoimmune response, leading to the destruction of beta cells and the development of type 1 diabetes. And it's thought that in many people, the development of type 1 diabetes takes many years. They've done a couple experiments that follow relatives of people with type 1 diabetes, so people who they expect to be at risk. So they've followed those people around, and they've noted that most of them who ended up later getting type 1 diabetes had certain autoantibodies or proteins that normally destroy bacteria or viruses kind of going bad and attacking your own tissues. They've had those autoantibodies in their blood for years before they ended up being diagnosed. So it does seem to be a slow developing process that they can sometimes detect. But it's really the combination of these genetic and environmental factors that lead to the development of type 1 diabetes. And one type of study that people love to look at when looking at genetics is twin studies, since identical twins are genetically identical when born. But research has shown that when one identical twin has type 1 diabetes, the other gets the disease at most only half the time. So that just demonstrates how strong the environmental factors play a role here too. So type 1 diabetes is often diagnosed when people are young, in childhood or adolescence, but sometimes it can present in adulthood as well. And because type 1 diabetes is an autoimmune condition, there's unfortunately no known way to prevent it or delay the onset of the condition. So in contrast, type 2 diabetes is a condition in which the pancreas secretes normal amounts of insulin, but the body doesn't respond properly, and this is called insulin resistance. So cells with insulin resistance cannot move the glucose transporter, this little purple guy known as the door. They can't move those to the surface of the cell, so the door doesn't open and glucose cannot enter. However, in later stages of type 2 diabetes, you can actually lose the ability to produce normal amounts of insulin similar to type 1. And this is because when the beta cells of the pancreas are secreting insulin, but the other cells aren't responding, so in insulin resistance, the beta cells try to compensate by increasing in number and size in order to secrete more insulin. They're really just trying to like overstimulate the other cells to get a response out of them. And this does work for a while, and with enough insulin, glucose can move into the cells, but this ends up being really tiring for the beta cells, and they end up becoming dysfunctional and atrophy or shrink and kind of die off. And this can end up leading to decreased insulin production and consequently hyperglycemia again. So this picture here is of the pancreatic islets where beta cells sit. So these little tiny purple cells in the center here are the beta cells. So those are the ones that will grow initially in response and then eventually shrink away and kind of atrophy. So type 2 diabetes, similar to type 1, is caused by a combination of genetic and environmental factors. And interestingly, it seems to have an even stronger genetic link than in type 1 diabetes. The environmental factors, though, are a bit more lifestyle related. It's not so much getting a virus or getting sick, anything like that. It's more related to people's lifestyle, access to healthy food, and healthcare. And it's often diagnosed in adulthood and later life. And that's why the risk for developing type 2 diabetes increases with age. And it's more so just as you age, your body has more time to interact with the environment and accumulate any sort of damage or concern that could lead to the development of type 2 diabetes. And there are some known ways to prevent type 2 diabetes or get it into remission, but you cannot completely cure type 2 diabetes. You can get it into remission, though, like I mentioned, and this is more likely in the early stages of type 2 diabetes, since the body is still able to make normal levels of insulin. Whereas in the later stages, it's less likely because the body may have lost the ability to make proper levels of insulin. So some risk factors for type 2 diabetes, there's some factors that you can't change, like your age. There's a higher risk over the age of 40 if you have a family history of type 2 diabetes. There's certain cultures or ethnicities that are at a higher risk as well. And then a couple other things that you can't always change. So environmental factors like lack of access to healthy food. There's 4 million Canadians that don't have access to affordable and healthy food, specifically in more rural and remote regions. And this definitely contributes to some environmental factors that people aren't necessarily able to overcome. But some other lifestyle factors that hopefully most people have the ability to overcome, lack of healthy eating, which can contribute to obesity, and obesity helps contribute to type 2 diabetes as well. We'll go over that in a second. Lack of physical activity as well can contribute to the development of type 2 diabetes. It's estimated that about 78% of adults and 91% of children and youth aren't getting the recommended amount of physical activity. So as you can imagine, that's a huge proportion of the population that could be amenable to some sort of lifestyle interventions to help reduce the risk. As well as smoking. So smoking just kind of exacerbates the process of some downstream complications of diabetes and inflammation that can lead to the development of it. And currently there's about 15% of Canadians that still smoke cigarettes. So how does obesity contribute to type 2 diabetes? I realize this picture is quite complicated. Don't worry about the words or all these funny little names, but I really just wanted to point out here that these yellow parts are the fat cells or adipocytes. So when you have more of them and they become larger, that is when someone can become obese or overweight. And these adipose cells or fat cells release things like free fatty acids, adipokines, and other molecules that lead to systemic inflammation. And this inflammation contributes to insulin resistance over on the right here, which eventually will decrease the insulin secretion. And this slide also points out how cardiovascular disease and diabetes have similar origins and are often intertwined. So this process is one of the theories of why people with diabetes or cardiovascular disease often can get both conditions. So pre-diabetes, this is actually a precursor to type 2 diabetes. It's not necessarily a different type of diabetes. It's just a condition in which your blood sugar levels are higher than normal, but they're not quite high enough to be diagnosed as type 2 diabetes. And it's estimated that about 6 million Canadians currently have type 2 or pre-diabetes, and half will go on to develop type 2 diabetes. And it often has no symptoms at all because the blood sugar levels aren't that kind of full-blown type 2 diabetes level. People may not be symptomatic, so it's really important to be screened regularly by your healthcare provider, especially if you're at increased risk. And we'll go over the screening guidelines a bit later. And we're also going to go over the diagnosis and the blood sugar levels that differentiate pre-diabetes from type 2 diabetes as well. So just hold put for that. Next up, gestational diabetes. So this is the diabetes that occurs during pregnancy as a result of insulin resistance. And what happens here is the placenta, which is this organ that is only ever around when someone is pregnant, it ends up producing hormones that prevent the body from being able to use insulin effectively, contributing to insulin resistance. So as the placenta grows, more of these hormones are produced, and this is why gestational diabetes occurs in the second and more commonly the third trimester, when the placenta is at its largest and producing the most of those insulin resistant promoting hormones. So when the pancreas cannot create enough insulin to overcome this resistance, that's when diabetes occurs. And this inability to overcome insulin resistance really, we think, occurs in a pancreas that's predisposed to diabetes. So that's why not every person who's pregnant will get gestational diabetes. It's someone who's predisposed to their pancreas not being able to overcome this insulin resistance. So what predisposes someone? There's some risk factors. So maternal age over 35, certain ethnicities are at higher risk as well. If the pregnant person is obese or has a BMI over 30, if they have a history of pre-diabetes or a parent or sibling with type 2 diabetes, as well polycystic ovary syndrome, which basically has some hormonal implications for insulin use, which are beyond the scope of this talk, but that is another risk factor. So why does gestational diabetes matter? It's because if it's undiagnosed or untreated, it can lead to two main complications with the baby. One is macrosomia, and that's just a fancy word for a large baby. So if they're considerably larger than typical, so over 8 pounds, 13 ounces, and this is due to high circulating levels of glucose from the mother. So because the mother's insulin resistant, they have high hyperglycemia and lots of glucose floating around in the blood, which then goes to the fetus. And just like how if we eat lots of sugar, we'll gain weight, if the fetus is exposed to lots of glucose, they gain weight as well. And that glucose gets converted into fat. So this can lead to some difficult births for the mother with higher risk for complications during delivery, mostly because the baby's large, so it's harder to birth. And as well, macrosomia puts the baby at increased risk of developing childhood obesity, as well as metabolic syndrome, which is a syndrome including high blood pressure, high blood sugar, some obesity, especially around the stomach, and high cholesterol. The other main complication associated with gestational diabetes is hypoglycemia, so low blood sugar in the newborn right after delivery. And this is due to the baby, when it was a fetus inside the mother, it's used to this high levels of glucose circulating around. So the baby compensates by producing lots of insulin, so it can uptake all that glucose it's exposed to. But once the baby's born, you remove the glucose from the mother, but the baby still has all this internal insulin circulating around, and that will quickly shove any glucose the baby has into the cells, which rapidly drops the blood glucose because it's all taken up into the cells. And this is at really high risk for brain damage. It can harm the brain's ability to function if you have decreased blood glucose. and could lead to things like seizures or brain injury in the newborn. But this picture here demonstrates that all newborns are checked for hypoglycemia, and there are some symptoms that the maternity team will look out for as well to make sure they pick up on that serious complication. And some long-term outcomes for gestational diabetes. There's an increased risk of the mother developing type 2 diabetes in the future after she's had gestational diabetes. There's also a subsequent risk of developing gestational diabetes in subsequent pregnancies. And like we talked about, increased risk for the baby of becoming overweight and developing type 2 diabetes in the future. Okay, so that was a lot of information. We're going to take a bit of our break now, so 10 minutes. I'll pause the presentation here, and when we come back, let's see, at 1:42, I'll have some time for questions as well. So take a break, and I'll see you at 1:42. 1:42 now. Okay, so welcome back everyone from our break. Hopefully you're able to stretch your legs, get a cup of tea. We'll go through the second half of our talk now. Let me just make sure I'm sharing here. Okay. So does anyone, first of all, have any questions on the first half of the talk? I didn't notice any in the chat. All right, so then we'll move on to the next half. So we're going to start talking about the complications of diabetes now. So you can group the complications into two main categories. One is macrovascular, which are effects that affect the larger blood vessels and structures in the body, and then microvascular, which affect the small blood vessels and structures of the body. So a poll here to get everyone awake after that little break. So which of these complications do you think are considered microvascular? So affecting the small blood vessels. Here we go. So the options are coronary artery disease, which are the arteries of the heart, peripheral artery disease, which are the arteries of the legs or arms, and nephropathy, which is damage to the kidneys. Okay, so a few more seconds here left in the poll. All right, so I'm going to stop it there. So let me share the results. So there's a bit of a split in your results. About half of people thought peripheral artery disease, but the other half thought nephropathy, and one vote for coronary artery disease. So the answer is actually nephropathy or kidney damage. And we're going to go through that. That's because the blood vessels that get affected in the kidney are really, really tiny. There's millions of them in each kidney, whereas peripheral artery disease is often of like the larger arteries in the legs or arms, and coronary artery disease, those blood vessels in the heart. So we'll stop sharing here. Okay, so macrovascular includes coronary artery disease, peripheral artery disease, as well as stroke. And microvascular includes neuropathy or damage to the nerves, nephropathy, damage to the kidneys, or retinopathy, damage to the retina in the eye. So we'll start off with macrovascular. So all these conditions involve damage to blood vessels, and how that occurs is hyperglycemia, as we talked about, is an inflammatory state, which leads to inflammation and damage of blood vessels. And when the blood vessels are inflamed, they respond by thickening. Plaques can start to form, known as atherosclerosis. So if you're interested in details of this process of how atherosclerosis develops, you can watch my vascular disease talk, which was recorded in the spring, and it's on Dr. Gare's website there. And maybe you attended that talk, so you're an expert now. But this damage is made worse by comorbid conditions, so things that occur oftentimes together, things like high blood pressure and high cholesterol, because that really speeds up the process of damage to the blood vessels. So we'll start off with coronary artery disease. So that's atherosclerosis of the coronary arteries, shown here, the blood vessels that feed the heart tissue itself. And this can eventually lead to a heart attack. So as the blood vessels, the coronary arteries narrow with plaque, this plaque can sometimes rupture, which then causes a blood clot to form, shown here in the bottom of the picture. And when that blood clot forms, that will block off all the flow to the heart and cause a heart attack or myocardial infarction. Also, angina, you may have heard of before. It's a type of chest pain, and it's caused by decreased blood flow to the heart, often caused by atherosclerosis. So it would just be lower levels of atherosclerosis. It's not fully blocking it off. But you often feel this chest pain when physically exerting yourself. And that's because it puts more demand on your heart. So the gap between the actual blood flow that you now need more blood flow. And the amount of flow that you're actually getting, which is smaller because you have a narrowed blood vessel from the plaque, that gap widens and you end up getting chest pain kind of as a sign of your heart not getting all the blood it needs. Next up, peripheral artery disease. So this is when atherosclerosis decreases blood flow to the legs and the feet. So there's a couple different signs and symptoms of this. So one, claudication pain mentioned here. You often have leg muscle pain or cramping with peripheral artery disease. So claudication is the onset of muscle pain, often in the calves, when exerting yourself or using the muscles. And this is due to inadequate blood flow from the plaque, which then can't meet the increased needs of the muscle during exercise. So it's similar to angina, that kind of pain just in your legs. And this type of pain, claudication, will resolve when you're at rest. Whereas rest pain, so as peripheral artery disease progresses, people can develop rest pain. And that's where someone feels pain in their muscles when they're not exercising or exerting themselves. And it's often worse when the legs are elevated because the artery is so narrowed that without the help of gravity, adequate blood flow cannot get to the muscles. So this type of pain tends to get better when you're standing or walking because the movement and gravity helps increase the blood flow. Some other signs and symptoms of peripheral artery disease would be when the skin and leg tissue is chronically deprived of oxygen and nutrients due to decreased blood flow. So you'll get things like numbness, weakness, leg hair loss, change in appearance of the skin. It may look shiny, dry, quite pale. Also the development of sores, which have difficulty healing. And that's because with the blood flow decrease, you're not getting enough oxygen and nutrients to the wound to help it to heal. And that also carries an increased risk of infection. And eventually, if this isn't treated or looked after, the feet can start to turn purple or black as the tissue starts dying from extreme lack of blood flow. And that may lead to the requirement of amputation. And as we mentioned earlier, diabetes is the leading cause of non-traumatic amputation. So stroke, the last macrovascular complication we'll talk about, that's when atherosclerosis can block blood flow to the brain due to either a plaque or a blood clot formation. So there's two types of stroke. Ischemic would be a blockage, or hemorrhagic, which is bleeding. So both of these cause reduced blood flow to the area, preventing the brain from getting oxygen and nutrients that it needs, which then can lead to the death of brain cells involved. But ischemic is far more common. It accounts for about 87% of strokes. And atherosclerosis of the arteries in the brain is one of the most common causes of ischemic stroke. So when the artery is narrowed by plaque, if the plaque ruptures, a blood clot can form similar to a heart attack, which can fully block off blood flow to that brain artery and the subsequent areas of the brain that are supposed to be fed by that artery. So that's shown over here on the left. An example of atherosclerosis, this little tiny arrow is showing kind of a blockage in the otherwise nice smooth white that you see. So that darker area is where a clot's forming and blood can't get through. And that can lead to damage shown here with this white patch on the brain. That's actually dying brain tissue. So it kind of lights up on this type of scan. And the other type of ischemic stroke can be caused by by a piece of plaque kind of breaking off from arteries other places in the body. So for example, carotid artery disease or arteries of the neck. When plaque builds up there, sometimes pieces of plaque can break off and travel to smaller arteries in the brain and cause a stroke. or a clot can form on that plaque and then block kind of everything upstream from that. So moving on to microvascular, this is the neuropathy, nephropathy, and retinopathy. So basically the nerves, kidneys, and eyes being damaged. So starting off with neuropathy, so hyperglycemia can damage nerves, which leads to symptoms of numbness, pain, and paresthesia, which is just a fancy word for burning and tingling sensations. And the nerves of the feet are commonly damaged first and most severely, which then can increase your risk of cuts and sores or blistered. And that's just because if you don't have sensation on your feet, you won't notice if you accidentally damage yourself. And if these initial wounds are not noticed or left untreated, it can lead to infection, gangrene, and eventually amputation being required if they're really not looked after. And the nerves of the feet being most commonly damaged, we don't fully understand the process of nerve damage in diabetes, but the thought is it's related to inflammation of the nerves themselves and damage to blood vessels, which help support and feed the nerves. So this theory kind of bases the thought on the nerves of the feet are furthest away from the body and spinal cord. So they're more vulnerable to damage because nutrients need to travel the furthest to reach them. So when something goes wrong, they're going to be the first that gets cut off. So this is called length-dependent neuropathy, and people may have sometimes called a stocking and glove distribution. So it will start at the toes and work its way up, kind of like stockings or socks. And gloves, the tips of fingers and hands are also further away. So those get affected regularly as well. And autonomic neuropathy, so this is damage to nerves that control involuntary bodily functions. So things that happen automatically without us controlling them. So this picture here on the right shows some connections between your brain and spinal cord and some organs, which we don't control. So for example, some innervation of the heartbeat, lungs, and some other GI organs and the bladder. So damage to nerves here can impact the ability of the brain to be able to talk to those organs. So you wouldn't be able to regulate things like digestion, sexual function, heart rate, and bladder control can all be interrupted. But for example, for heart rate, so if the brain isn't able to talk to the heart and they're not able to communicate what's going on, for example, if you're working out or exercising, normally your brain would signal your heart to increase so that you can increase your exercise capacity. But with damage to these nerves, the heart can't adjust to the activity and it will stay nice and slow, which then leads to you to have a bit of intolerance to exercise because you're exercising, but your heart rate's not increasing. And that's uncomfortable because you're not able to meet the increasing demands of all the tissues and other body parts that need it. And next up here, nephropathy, where this is damage to the tiny blood vessels in the kidneys. And up to 50% of people with diabetes will eventually develop chronic kidney disease. And if this is left untreated, the kidneys will eventually fail, leading to end-stage renal disease, which diabetes is the #1 cause of. And when someone has end-stage renal disease, they often require dialysis or a kidney transplant to help with kidney function. So just to orient you to the pictures here, so on the left is the kidney kind of sliced down the middle. And these little triangular red structures, those are called the pyramids of the kidney. So if you look on the right here, this little pyramid will contain things called nephrons, which are the functional units of the kidney. And then zooming in within a nephron, you'll have this little bundle of tiny, tiny blood vessels called the glomerulus. And I'll move to the next slide here. So this is kind of zoomed in on the glomerulus. So that's the structure, a bunch of tiny blood vessels that help the kidney filter waste products out of the blood into the urine. So the normal glomerulus helps keep protein and molecules in the blood and will filter out other waste products to create urine. But in diabetes, you get kind of leaking of this blood vessels here, which creates other things getting into the urine that aren't normally there. So there's something called the afferent arteriole, which is the blood vessel that brings blood into the glomerulus. That's shown here. And the efferent arteriole, which is the one that helps the blood leave the glomerulus once it's done being filtered. So hyperglycemia leads to thickening and constriction of the efferent arteriole, or the one that helps blood leave. And this ends up obstructing blood from leaving the glomerulus, and that creates a higher pressure within the glomerulus itself. And then you also get dilation of the afferent arteriole, or the one that brings blood in. So that just really compounds the problem and allows even more blood to enter, increasing the pressure even more. And increased pressure leads to increased filtration within the glomerulus, or increased, you may have heard GFR before. It's a test that your doctor will sometimes do to measure your kidney function. So with increased GFR, or increased filtration in the glomerulus, it'll end up push things out like proteins into the urine that wouldn't normally be there. So this is why proteins such as albumin is tested for in the urine of people with diabetes or people at risk of kidney disease as a way to monitor the health or function of kidneys. But over time, this overfiltration and increased pressure within the glomerulus damages it and will eventually lead to reduced ability to filter blood, so the GFR drops. And eventually this can contribute to chronic kidney disease because the kidneys no longer function properly and filter at a much slower rate. And lastly here, we'll go into retinopathy. So this is damage of the tiny blood vessels in the back of the eye. So the retina is a layer that lines the whole inside of the eye, and the retina contains the sensory neurons, which help you perceive light, and also a bunch of tiny blood vessels to help feed that really delicate tissue. So what happens is high blood sugar or hyperglycemia can cause the really delicate blood vessels here in the retina to swell and start leaking into the retina, and this can lead to blurry vision or blind spots in the vision. And this is in contrast to the blurry vision that you get with more acute hyperglycemia with the lens swelling. This is more of a long-term complication. And so when you get these bleeds into the retina, the blood doesn't end up going where it's supposed to. So you have areas of the retina that end up getting blood into, and then the downstream areas that are supposed to get blood don't end up getting it because they've kind of diverted into the other parts of the retina. And that leads to certain parts of the retina being deprived of oxygen. And that signals new blood vessels to grow because it's trying to compensate for this lack of oxygen and blood getting to certain areas. But then to make the problem worse, these tiny new blood vessels that start growing, they're not very good. They're really fragile. They're even more prone to leaking. And that can lead to subsequent leaks and bleeds and more blurry vision and further damage. So it's kind of like a perfect storm. Once you start getting bleeds, it sends the signal cascade off that just makes you more prone to bleeds. So some pictures here of retinopathy. So on the top here, this would be if you're looking straight in through someone's pupil into the back of their eye. This white part is the optic nerve, or the head of the optic nerve, which carries all the nerves from the eye into the brain. So looking straight in at the back of the retina, this is a healthy one. And shown down here are progressively worse retinopathy. So over on the right here, you can start to see little tiny bleeds. I know the picture is pretty small, but little tiny bleeds and some kind of white patches known as cotton wool spots, or exudates, which are things that would normally be in the blood, like proteins and stuff. They can be pushed out when you have those retinal bleeds. And then further on the right here, PDR stands for proliferative diabetic retinopathy. And that's the stage when the new blood vessels start to grow or proliferate, and you get just exaggerated bleeding and damage to the retina. And then this funky looking green picture on the right here. So the bottom is what the normal retina would look like. So this is actually a cross section of the retina. So if you look at this image at the top, if you took a slice right the way through, just kind of like this, and looked at it on edge, these are the layers of all the sensory receptors and tissues that make up the retina. So you can see this is nice and smooth, and that would contribute to nice clear vision. Whereas on the top, this is an example of diabetic macular edema. So that's when fluid from the bleeds in the eye start to build up within the layers of the retina. As you can imagine, all this kind of bumpiness and pockets of fluid really distorts the vision, where normally you would require nice smooth layers of sensory receptors. They get distorted. That can lead to blurry vision, blind spots in your vision, and also kind of wavy vision as well. All right, so now we're going to move on to the diagnosis section of our talk. So when and how are people screened and diagnosed with diabetes? So this is a bit of a flow chart here from Diabetes Canada. But the main thing I'll just point out here is screening for type 2 diabetes in Canada is recommended to start at the age of 40 for people who are not at high risk for the condition. So most people, the average population, they just start being screened at age 40. And it's recommended to be screened younger than that if you are deemed to be high risk for diabetes. So once you start screening at 40, you should be screened once every 3 years from there on out. And if you have any of the risk factors listed up top here, so a family history of type 2 diabetes, if you have a history of gestational diabetes or pre-diabetes, heart disease, other kind of signs that something might be going on in your body related to diabetes, like organ damage, then it's recommended to be screened every 6 to 12 months, a bit more frequently, just to keep on top of it. And just to note here, type 1 diabetes is not screened for because there's no evidence to support interventions being able to prevent or delay the onset. So this is specifically for type 2 diabetes. So how is diabetes screened for? So screening is mostly done by checking the levels of blood glucose. So if you take a blood sample, they can measure the levels of glucose in the blood. And you typically need 2 positive tests to make a formal diagnosis. So it's recommended to have the same test done on 2 different days. But I know sometimes healthcare professionals, if they want to get a really quick diagnosis, they may just order 2 different tests on the same day to get that same result. So a couple different ways to measure the level of glucose in the blood. The first one, fasting plasma glucose. So this is when you have someone fast for 8 hours and then the glucose levels are measured in the blood afterwards. So when you fast, you don't have that food intake contributing to your blood sugar levels. And because you're fasting, you're kind of in a hypoglycemic state or low blood sugar. So your liver ends up releasing some stored glucose that it was holding on to for times like this. So it releases stored glucose into the blood. And in response, if your pancreas is working properly, it should release some insulin into the blood as well to bring the glucose levels back down. But in people with diabetes, the action of insulin either won't occur properly or your body won't respond to it properly. And so the glucose levels stay elevated. So these are just some numbers here. So pre-diabetes would be if your fasting plasma glucose is around 6.1 to 6.9, whereas type 2 diabetes would be diagnosed above 7. The next one is hemoglobin A1C, something I think probably most people are pretty familiar with because it's quite a common test to be done. So hemoglobin is a protein in your red blood cells that carries oxygen. And so hemoglobin becomes glycolated or coated with sugar as it comes across glucose in the blood. And so this test determines the percent of hemoglobin proteins in your blood that are coated with sugar. And this is a really nice screening and monitoring test because the hemoglobin A1C levels reflect your average blood sugar for the past 3 months. So that's a really helpful test. And I've started just fasting plasma glucose and hemoglobin A1C because those are the recommended screening tests. So something you might get done once every 3 years or once every year. Next, oral glucose tolerance test. This measures your body's response to glucose. So you'll actually drink a really syrupy glucose solution, and then 1 or 2 hours later, your blood glucose levels will be measured. So this is the main test that they use in pregnant people to test for gestational diabetes. And lastly, random plasma glucose. So this is simply taking a random measurement of your blood sugar. So it's not really used as much as screening because there's quite a variability in your blood glucose levels depending whether you ate last or fasting, that sorts of thing. But it is noted that if your random plasma glucose level is over 11.1, that is far enough outside the normal range, even if you had just eaten to signify diabetes. And this is just a little pictorial demonstration of hemoglobin A1C. So you have your red blood cells here. If you zoom in, there's this protein called hemoglobin that carries oxygen. So the hemoglobin itself starts to get coated in sugar. So this would be an example of a high A1C. There's lots of sugar coating it, and a low A1C. There's not as much sugar just because it hasn't come across as much sugar in the blood. So as I mentioned, type 1 diabetes is not screened for. And unlike type 2 diabetes, type 1 often presents acutely. So it's not recommended to wait for a confirmatory test before treating. So you wouldn't do one test and have them come back a couple of days later to do the same test again, because it often presents quite acutely and people can be in distress when this happens. So if someone's symptomatic, they have some of these symptoms going on, and they have one positive screen for high blood sugar, that's enough to kind of call it type 1 diabetes for right now and start treatment. And then later down the road, they will do some confirmatory tests to make sure. Now, sometimes if someone doesn't present acutely and they're not really young, kind of like the normal picture of type 1 diabetes, you may need to do some special tests to differentiate type 1 from type 2. So there's a couple different tests. One is called a C-peptide test. And C-peptide is a little protein that's made in equal amounts to insulin within the pancreas. So it'll be low in people with type 1 diabetes because they're not creating enough insulin, and normal or high in those with type 2 diabetes because they are able to create the insulin. And C-peptide is measured instead of insulin because insulin goes through a bunch of different metabolic processes in the body. And when you measure it, that's not exactly a good true demonstration of how much your pancreas is creating because it could have been used up or metabolized, that sort of thing. Whereas C-peptide, once it's created, it doesn't really have a use. So it will be in the same level that's created at if you measure it later on. So autoantibody panel or islet autoantibodies. So as a reminder again, autoantibodies are antibodies against your own tissue. So this test specifically looks for autoantibodies for the pancreas. And so since type 1 diabetes is an autoimmune condition, markers of this reaction can be measured in the blood. So autoantibodies will be present in type 1 diabetes and completely absent in type 2 diabetes. And this picture at the top is just a little picture of an antibody. So how do we diagnose gestational diabetes? So every pregnant person is recommended to be screened for between weeks 24 and 28 of gestation. And like I mentioned, the oral glucose tolerance test is performed. So initially they recommend using the 50 grams, so that's just the amount of glucose in the solution, the 50-gram oral glucose tolerance test. So you'll have the pregnant person drink that, and then an hour later, their blood sugar will be measured. So if the blood sugar is over 11.1, that's enough to diagnose gestational diabetes. If it's kind of in this pre-diabetes stage, slightly elevated, but not high enough to be diagnostic yet, the 7.8 to 11, then it's recommended to repeat this test using the 75-gram glucose. So drink a higher level of sugar, and then there's some further kind of diagnostics they do after that. Now we're coming into the treatment section of our talk. So diabetes is managed through a combination of medication and lifestyle changes. And the things we're going to be going through in the treatment section are working with your healthcare team to achieve your diabetic targets. I'm going to go through a couple different common medications. There's tons of different diabetes medications on the market, and I'm sure there's more coming out every day, but the two main ones that will come up are insulin and metformin. So I'll talk about those two. Lifestyle management, and this kind of clever catchphrase that I think that Diabetes Canada coined is know your ABCDEs. So we'll go through all of those now. So the targets for glycemic control or blood sugar control, the general target for people with type 2 diabetes is to get their hemoglobin A1C under 7. So that's this range here. And under 6.5 if possible, just because they've had some studies to show that if the hemoglobin A1C is kept really tightly controlled under 6.5, then that reduces the risk of chronic kidney disease and retinopathy. But that's often not quite attainable for most people, so 7 is what we aim for. And then as people become older or a bit more vulnerable, the A1C targets increase. And that's to reduce the risk of hypoglycemia or the blood sugar becoming too low. because there's some quite drastic complications that can occur with low blood sugar. People can become dizzy, lose consciousness, become a bit delirious, and there's high risks of falling. So as you can imagine, in someone who's elderly or frail, you really want to reduce the risk of falls. So it will increase up to about 8.5, because over 8.5, the risks of hypoglycemia don't outweigh the risks of hyperglycemia, just because over 8.5, there's quite a few diabetic risks associated with that. And an interesting little memory trick that one of our professors talked about, I think in first year med school for A1C, is that as people age, so people over 70, you kind of take their age and you move the decimal place over 1, and that's what the target should be. So for example, if someone's 75, the A1C might be brought up to 7.5. So that's kind of an interesting tool. So how do we keep the glucose levels within our target range? So type 1 diabetics will often be on insulin because they're not able to create insulin themselves. They require this outside source to replace their body's insulin. And insulin is injected into the body. A lot of people with type 1 diabetes will have this kind of continuous insulin port here. So it's this little kind of sticker that you stick on. It has a tiny little needle that goes into the fat tissue just below the skin. And then they have a little programming device that they can set the amount of insulin they need to be introduced into their body based on what they're eating. There's also something called a continuous glucose monitor. So this is a little thing that sticks onto the skin as well, and it detects your levels of blood glucose like accurately at that point in time. And so it will signal someone's phone or another device what the glucose levels are. It will let you know if it's too high or too low. And it's also really handy because it keeps a record for your healthcare provider to look over afterwards to see what your normal glucose levels do. And so when using insulin, it needs to be monitored really closely to prevent hypoglycemia, because as we know, glucose opens up the door so that glucose can enter the cell. So if you have too much insulin or you're not watching that, glucose can flood into the cells and decrease in the blood, leading to hypoglycemia. Next up is metformin, and this is often used to treat type 2 diabetes and prediabetes as well. And it's an oral medication that decreases the amount of glucose absorbed in the intestines and also the amount of glucose that's produced in the liver. So its overall effect is to decrease the blood glucose levels. And I'm not going to go fully into the whole glucose metabolism and how it's absorbed or produced by the body, because there's lots of different tissues involved. But yeah, the main thing glucose does is it will decrease your absorption in the gut, decrease the amount the liver is going to let go of and put into the blood, and also enhance a bit of uptake within the muscles and fat cells. So what's nice about metformin is there's no significant risk of hypoglycemia because it doesn't affect the insulin. So it's not going to cause your body to suck up glucose into the cells quickly and drastically drop your blood glucose levels. It does so in a more moderate effect, so you don't have the risk of hypoglycemia and its associated complications. And I just thought I'd add this little aside in here about treatment, because some of you may have heard about this in the news recently. There is the talks about a potential cure for type 1 diabetes with stem cells. So this new research is starting to show the ability of labs to be able to convert stem cells into pancreatic beta cells, so the cells that produce insulin. And it says new research because they've finally come to a conclusion now, but they've been working on this particular lab has been studying this for the past 20 years. So it's taken 20 years for them to be able to figure out how to convert stem cells into beta cells that actually work and produce insulin. So this is really in the news right now because this past summer, I think in June, the first person with type 1 diabetes was injected with these beta cells that were created from stem cells. And they're replacing the lost beta cells that this person had due to their autoimmune type 1 diabetes. And they're noticing now that they're actually functioning properly. So these beta cells have integrated into his pancreas and they're producing insulin and responding to his blood glucose levels, which is incredible. He doesn't need to monitor his glucose while he's eating. And he noticed, I think, the first couple meals, he would eat food, not give himself his normal insulin injection, and his blood glucose was in a normal range because the beta cells were working properly. So that's incredible. And then something to note here is just that the patients who have this procedure done need to be on immune suppressing medicine for life, because you can think of it like an organ transplant. These cells are not your own, and your body will try to attack them and reject them if it's able to. So they need to be on these medicine to suppress their immune system and prevent rejection. And this is still in its very early stages. I think they've only had one person who's been treated and have a successful outcome, but they're hoping to continue this trial into the future. And hopefully after a few years, it won't be too expensive, but I imagine this type of treatment will be out of reach for a lot of people, unfortunately, because it's a very expensive process to get this to work properly. So now back to our regularly scheduled programming. So lifestyle management for diabetes. So if you remember from the beginning of the talk, insulin needs to open the door to let the glucose into the cells. So during exercise, the door to the cell can actually be opened independently of glucose or insulin. So you don't need the key, the insulin, to sit into this insulin receptor lock to open the door. Exercise actually creates a new key. Exercise itself is the key that lets glucose enter the cells. So on the left here would be when you're at rest, not moving around like normal, you need insulin to open the door to let the glucose transporter move to the surface of the cell to let glucose in. But when you're exercising, and just to note, this is only during active exercise and contraction of muscles, this effect doesn't continue on after the fact. But during exercise, it actually produces this kind of downstream chemical reaction that causes the glucose transporter to move to the surface of the cell to let glucose in. So exercise kind of creates a backdoor to let glucose into the cell, which is incredible because with type 1 diabetes, as you know, you don't have insulin, so you don't even have the key. And in type 2, you have insulin, but the door isn't going to respond properly. So neither of those matter when you're exercising because you have a temporary backdoor that just kind of works right around insulin. And next up, exercise not only allows glucose to enter your cell without insulin, but it increases your sensitivity to the insulin that you do have. So your cells are better able to use any available insulin to take glucose up into the cells. So this is kind of thought of as reducing insulin resistance. So that's why it's recommended for all people, but especially people with diabetes, to exercise and exercise as regularly as possible, because you get these additional benefits of being able to uptake and use glucose and insulin correctly in a way that your body wouldn't normally be doing when you're at rest. And a little reminder of what the recommended exercise guidelines are. It's 150 minutes of mild or moderate to vigorous exercise per week, plus a bit of strength training. And if you're interested more about the guidelines and benefits of exercise, you can watch Julia, my colleague's talk on exercise from last spring. I think there's two or three different talks that she did, and those are on Dr. Gare's website right now. So the last form of treatment I'm going to talk about here for lifestyle management is diet. So the Mediterranean diet has been shown to improve fasting glucose levels as well as the hemoglobin A1C levels in people with type 2 diabetes. And it's also been found that a subset of the Mediterranean diet, a low carb version, demonstrated even better glycemic benefit. And Mediterranean diet is great because it's not only good just for reducing your blood sugar levels, but it has positive effects on inflammatory markers and may reduce the risk of things like atherosclerosis and other related complications like heart disease and progression of diabetic complications too. And low glycemic foods and drinks are recommended as well for people with diabetes to help control the blood sugar. So glycemic index is a ranking system that ranks carbohydrate-containing foods based on how much they raise the blood glucose levels when consumed. So a low glycemic index food has a score of under 55, medium is 56 to 69, and high is over 70. So for example, a low GI food would be things like apples, nuts, brown rice. Medium GI food would be things like pineapples, white rice, And high GI foods would be something more processed like white bread or chips, but also some fruits as well, like dates, because they're quite high in sugar. And just to note as well, there are some packaged foods that have some special labels for diabetes, and they'll kind of mention if it's diabetes friendly and have the GI noted. And things like that are really helpful because someone with type 1 diabetes, when they're using their insulin, they need to actually enter in how much insulin to inject into themselves sometimes. And they'll do that based on kind of guessing how much the food they're about to eat will spike their glucose levels. So they'll enter the insulin in accordingly to try to balance that out and not go too hypoglycemic or too hyperglycemic. And if you're more interested in the different diets and any nutrition research, you can also watch Alexandra and my talk from last spring on nutrition. It's also on Dr. Guerra's website. So another poll here. So which of these foods do you think does not have low glycemic index? So let me pull this up. Okay, so we've got 5 options: quinoa, which is a type of grain, popcorn, jasmine rice, apples, and berries. Which one do you think does not have a low glycemic index? All right, let's give a few more seconds here to answer if you haven't already. All right, so I'll end the poll here and I'll share the results. So the majority of you got it correct. So jasmine rice is a type of white rice, so that would be a medium GI food, but the rest are actually low GI foods. Even things like popcorn, because it's not a refined snack food. I know we kind of eat it like chips and stuff, but it's actually still a grain and it has a low GI. Apples and berries, I thought it'd be nice to throw in there because it highlights how things like fruits are still healthy to eat when you have diabetes, and good options, especially too, because they're healthy sources of lots of different vitamins and minerals. So we'll stop sharing there. All right, so now on to the ABCDEs of staying healthy with your diabetes. So this is kind of an acronym to remember a few things to help keep yourself healthy and monitor your diabetes and any potential complications. So A stands for A1C. So making sure that you're keeping on top of your glycemic targets, normally around 7% or less for your A1C levels. B is for blood pressure control. The normal population, or like the regular population, is recommended to keep their blood pressure below 140/90, but with people with diabetes, because they're more prone to kidney damage, it's recommended to keep your blood pressure even lower, so under 130/80, because high blood pressure can damage the tiny little blood vessels in your kidneys and accelerate that process, as well as other processes like atherosclerosis and things like that developing. Cholesterol. So LDL cholesterol is known as your bad cholesterol, and it should be kept below 2. And that's just because cholesterol can contribute to plaque formation, which already occurs quite commonly in diabetes. D is for drugs to decrease your heart disease risk. So making sure you're taking blood pressure pills or cholesterol lowering pills or your aspirin, anything that's recommended by your doctor to reduce your risk of developing diabetic complications. E is for exercise and healthy eating. So making sure you're exercising, making use of that back door that a lot of people don't know that we have to get glucose into your cells and lower your blood glucose. And also eating a healthy diet that reduces the spikes in your blood glucose and can help keep your A1C targets under control. And then the S is self-management support. So diabetes is a chronic condition, and it can take a lot of work to kind of manage it and keep on top of it. So it's good to have a nice support system to help you with that, as well as setting goals for yourself. If you're trying to improve your lifestyle or your glycemic targets, for example, going on 1 extra walk per week, or doing 30 minutes of some sort of movement every day. Any sort of goals you set are great, and having a support network to help you maintain those goals is even better. The other S is for screening. So it's recommended that people with diabetes have annual screening for their eyes, get their kidneys monitored or the kidney function, have their nerves and their feet checked, and as well make sure their heart is functioning properly as well. And the final S is for stopping smoking. And so smoking cessation is highlighted here because in combination with diabetes, smoking dramatically increases the damage to the blood vessels and the subsequent complications that arise from that. So the heart attack, stroke, eye, kidney, and nerve problems. So it's really important to try to stop smoking cigarettes for everyone, but for especially people with diabetes. And then a final little note here just on prevention. So as noted, I think in one of those infographics earlier by Diabetes Canada, they note that more than half of people with pre-diabetes can delay or prevent the onset of type 2 diabetes if they make some lifestyle changes. So like we talked about, following a healthy diet. And I think it's really important here. There's a lot of kind of dieting and talk about that all the time online or between people. But I think a good way to think about it is more about adding things into your diet rather than restricting, because our society is very big on restricting and diets in that sense. But think about what you can add to each meal. Can you add some extra vegetables or whole grains instead of, refined grains? Have a banana with breakfast or an apple instead. As well, exercising regularly. So starting slowly, because everything does count. Anytime you're exercising and contracting your muscles, you are activating that little back door of reducing your blood glucose and helping to improve your insulin sensitivity. So don't be disheartened if you're not meeting the recommended 150 minutes a week, but try to work to that if you can. So try to pick an activity you enjoy, maybe find some friends to go for a walk with regularly, and just kind of keep focusing on the benefits that can have for your entire body. And then as well, if indicated, weight management can help prevent diabetes, as we talked about. Obesity and more fat cells in your body increase the inflammation, and that can downstream affect your pancreas and the amount of insulin that's produced and the sensitivity of the insulin as well. And then finally, knowing your ABCDEs, we just talked about keeping on top of your health, knowing, what conditions you have, how you're recommended to monitor them, and speaking to your healthcare provider to try to meet your goals. And then as well, talking to your healthcare provider if you're concerned at all about your risk for diabetes. So you have a family member or you yourself are just interested in how you can improve your lifestyle or diabetic complication risk. And then follow routine screening guidelines. So getting your recommended screening once every 3 years, if kind of at a low risk, or every year, if that's something your doctor recommends. So we're at the end of the talk here. I have a couple of resources to just run through. So Diabetes Canada is a wonderful resource. I use them for most of this talk creation. It's got lots of different information on each type of diabetes, resources for eating and meal planning, as well as exercise. Basically everything you'd want to know about diabetes and its management can be found on this website. So definitely check that out if you're interested. And it's pretty easy to navigate too. Most of the stuff is kind of on the left of the screen that you can get back to easily. HealthLink BC is not as easy of a site to navigate. So I put a couple specific links here that relate to diabetes, so you don't have to try to figure out how to find them on the site on your own. So it has a section on healthy eating resources for people with diabetes. And this links mostly back to Diabetes Canada, actually, but it lays it out quite nicely for different topics if you're interested. And they as well have a page on reading food labels for diabetes. So how to understand the nutrition facts labels, what different things mean and how they can impact your blood sugar levels. Heart and Stroke as well has some specific resources on heart-specific info related to people with diabetes. And as well, Quit Now is a free smoking cessation resource or program for all British Columbians. So it's really nice and a good free resource if you currently smoke cigarettes and are looking to make some changes with regards to that. And then also you can telephone 811, it's the HealthLink BC phone number, 711 for the hearing impaired. And on that phone line, you can speak to a registered nurse, registered dietitian, exercise professional, or pharmacist, and talk about any concerns or questions you have about diabetes management or some kind of tips for prevention and improving your health outcomes. And always your general healthcare provider, your physician or nurse practitioner as well is a great resource to go to. So that's the end of our talk. I'll open it up to some questions and I'll look through the chat to see if there's anything that's been posted. But otherwise, I just want to say thank you to Dr. Gare, who's our supervisor for this mini med school activity, and my classmates, Julia and Drew, who attended today and helped support everyone by posting in the chat and recording the session. And thank you for attending today. I'll just leave up our future talk list. So our next talks aren't going to happen until the new year. We have 6 more talks to go. And just a reminder as well, if you think at all, you might attend 6 or more talks throughout our mini med school session in the fall and winter here, please do consider filling out our survey if you haven't already. So let me just look through the chat here. Oh, it looks like everyone, my colleagues have kind of responded to questions as they've come up. So thank you very much. It doesn't look like there's any other questions. So this talk will be posted on Dr. Gare's website, the link that is in the email you received to get the link to our Zoom talk today. And the slides will be posted as well for you to look over too. So you don't need to worry about, if you didn't get everything down or miss certain things. So thanks so much, everyone. You're free to go. And I hope to see you all at our next talk on January 16th on common medications and how they work. Hope you have a great holiday season, and we'll see you in the new year.